Hi, I'm Dr. Alvaro Ordonez. It's a real pleasure to be with you today, sharing a little bit of the work that we're doing with our patients in our practice. As you can see, we're not going to be talking today about pretty or beautiful implant dentistry. We're going to be talking about different aspects that will make the process of thinking in your practice probably better, more comfortable, and will help you eliminate some complications that we come across during our everyday work in practice, which can sometimes be a little hectic, a little stressful. I'm going to share with you tips to make it easier. I have divided this process in 10 different pointers. Feel free to use what is good for you and just let go whatever you think that you don't have to use. That's why I said leave the gun and take the cannoli. Whatever is sweet and you like, just take it. So I have not received any kind of compensation for this lecture, and I am not under any contract with any company at all. So what you get is what it is and the way that we practice. I want to dedicate this lecture to my good friend, Dr. Kenneth Judy, and I also want to dedicate it to Carl Misch, both founders of the ICOI. And today I just did this presentation on main podium, and I had the honor to have Dr. Ronald Buehler introduce me. And Dr. Ronald Buehler was the first person ever to give me the chance to show my cases in implant dentistry. I'm very thankful to him, and it was special today to have him introduce me at the World Congress. So I live in Miami. I've been living in Miami for 25 years. I practice in South Miami, a fantastic city. If any of you is ever visiting Miami and want to go visit us in our practice, you're welcome to come and share some clinical time with us. And if you don't want any kind of clinical time, if you just want to have a little bit of fun, let me know and we can go in the boat fishing or we can go for dinner. We are a TMJ and Orofacial Pain Center, a sleep dentistry center. I had the unique privilege and opportunity to attend the training at Tufts University at the Orofacial Pain Center from 93 to 96 under the supervision of Dr. Noshir Mehta, Harold Gelb, Albert Forgioni, and all the different concepts that you are gonna hear today. Most of them are their concepts that I have been able to modify and implement into the type of work that we are doing with the pain patients. And also we have been able to actually pass this on to the implant patients that we treat, and it happens to work pretty well. You know that we live, when it comes to TMJ and it comes to orofacial pain, we live in a world of complexity. The TMJ patient, the orofacial pain patient, is known as a complex patient, and the diagnosis, which is the key to unravel the whole problem, it's a complex process. And one of the good things that we have had with Dr. Mehta is the fact that he was able to create a checklist to be able to get to a diagnosis in a simple manner. Dr. Mehta has been the king of simplifying complexity, and I also have been able to pass that into the type of implant dentistry that I do. The TMJ and Orofacial Pain Center usually, not all of them, but usually have to come along with complex personalities and complex occlusions. Sometimes, not always, there are some TMJ patients that have fantastic occlusions and they just happen to clench, for example, or they are having other medical problems that affect the whole head and neck system. There are also usually, I would say 98% of the time, we have exposure to complex forces, and there is the development of pain and dysfunction in the head and neck and face. Sometimes that pain and that dysfunction can travel to remote areas as far as the hips, just to give you an example. And the management can be as simple as you can make it or as complex as you as a clinician can make it. Many school of thoughts tend to make it complicated. And again, the school of thought that I'm coming from, which is at the TMJ Center at Tufts, and we like to call it the Northeast Craniomandibular School of Thought, which involve also New York areas, Connecticut areas, New Jersey. These people are very good at simplifying this whole process for the management of the TMJ and orofacial pain patient. The maintenance is important important once you improve the dysfunction of the patient, and once you improve the pain of the patient, and you get the patient to a relatively good health situation and relative good health condition, you need to maintain that, and in the process every day try to make it even better. And then you have to get into a finishing type of technique that very often involves implant dentistry. So again, the first thing that we do with our patients is eliminate pain, restore function. 90% of the implant patients that I've been lecturing on my whole career have been implant patients that had TMJ disorders, had TMJ dysfunction, and were treated before. And I usually don't get to talk about this topic because doctors are mainly interested in learning how to graft, learning how to deal with soft tissues, how to restore, how to do all the virtual planning, digital flow. And fortunately, I've been involved in the development of many of the different devices, technologies, softwares. So usually I'm showing that and not exactly what we do behind the scenes that we usually don't share because we don't get invited to share this. Implant dentistry, as I said, then it becomes an alternative technique to restore missing teeth in these patients. And our implants, we know that are going to be under heavy parafunctional forces. They are going to be under attack, and we better do them right. We better exceed the conditions that surround this implant, exceed the volumes of bone, get the best of tissues that we can get the best prosthetics, the best occlusal tables. And if I had to say one thing, just go back to comprehensive implant dentistry and go into the biomechanics chapter, go into all the chapters that Mish very masterly put together to learn how to handle forces. He did a great job describing what we had to do. It's very comprehensive. So comprehensive implant dentistry would be the right book to understand what you need to do to protect those implants, those restorations, those tissues surrounding the implants of these heavy forces. And the occlusion of these patients with orofacial pain are usually very, very messy. If you can handle one of these guys, then when you get a normal everyday patient without parafunctional forces, you usually have an easy life because all you have to concentrate is in handling the bone, handling the soft tissues, and doing what you need to do. You don't have that extra situation that have to do with the management of the forces and the pain and the dysfunction. Now, the management of the forces should always be considered because a patient that doesn't have parafunctional forces today could have parafunctional forces tomorrow. And when you think of forces and you think of biomechanics, you have to consider the fact that the whole apparatus of the mandible and the cranium and the glenoid fossa and the intercommunication with muscles, ligaments is a class 3 level. We have 3 classes of lever, type 1, type 2, type 3, and the TMJ itself functions as a class 3 lever. And then when we think about all these structures that you see that surround the TMJ, including the suprahyoid muscles, the infrahyoid muscles, and the connections to the base of the neck to the scapula, when we see all these interconnections, we have to consider the fact that our implant dentistry is going to affect the head and neck system. And if we put together that class 1 lever of the neck system, and we put it together with the class 3 lever of the TMJ, and we combine it, we have what is called a compound lever. And if we then add additional levers to each one of the vertebrae and additional levers to the shoulders, then we're going to see that we're dealing with a high complexity biomechanical situation in which our muscles, ligaments participating, proprioceptive mechanisms, the brain itself making decisions, and then the everyday life with gravity and all these other aspects that complicate the things. And in between, we have implants connected to restorations, connected to the bone that are supposed to be part of this whole mechanism, and we better make good designs, or we're gonna sometimes have to deal with issues. And these issues are percentual. That's not going to happen in every patient. You're going to have a percentage. It could be about 2% of the population that are going to complicate. But when you have that complication, it becomes your whole attention, because it really messes up the everyday life, you know. A problem with a patient, we dentists, we take it very seriously, and it really affects our well-being. So very, very important to understand many of the tips that we're going to give you. And why am I talking about this situation? I'm talking about this situation because occlusion and biomechanics have a lot to do with restoring an implant, with placing an implant, with creating the right foundations for that implant, and everything starts there. The reason that we put crowns is not only for cosmetics. The reason that we put crowns is also for function. And the head and neck are usually left behind when we refer and when we speak about function in implant dentistry. And our implant dentistry is creating effects into these structures, and a structure that we usually don't even think about. So very important to start introducing these concepts into implant dentistry. Remember, this is a field of evolution. So the question then, in one of the 10 pointers, would be, what kind of practice do you want to have? Because we're talking about the complex patient, and you have to ask yourself if that practice is set up for your intended procedure and management. The practice that you want to have, if you want to take a general practice, for example, into becoming an implant dentistry practice, you need to get what you need, and you need to organize it. You need everything that you need to do good implant dentistry, including time. You cannot be running from chair to chair. You have to sit down, dedicate the right time, the right attention to the patient. Otherwise, things are going to get more complex. The big question would be, what makes an implant patient complex? And this is one of the things that we usually discuss between colleagues. What makes an implant patient complex? Is it related to the technical, surgical, prosthetic complexity? I mean, is it a difficult surgical procedure? Is it a difficult prosthetic procedure? Does it have to do basically with the management of a specific human being, with their personality? Does it have to do with the field that is not totally invented and that we haven't finished the development of the field? Does it have to do with the budget that we have available to do a specific case? Is it a combination of the different pointers that I just mentioned to you? What makes that implant patient complex? If you can answer this question with the specific patient that you are dealing with, even before you start treatment, then you are going to be able to simplify the situation, because you have identified that situation that can make or create complexity in the management of this specific case. So the big question is, are you dealing with a complex personality, or are you dealing with a complex clinical procedure, or are you dealing with both? And in this aspect, Donald Redelmeyer, back in 2021, wrote a very interesting paper where he divided or created a 5-factor model for understanding patients' personality in medical care. And I think this is very relevant. And all you have to do is go online and Google this specific paper. And he divided in openness, conscientiousness, extraversion, agreeableness, and neuroticism. And if you get in there and you read this paper and you divide each one of these pointers and you understand the different personalities, it's going to be easier for you to identify the potential patient that is going to flow with you into success, that is going to probably go with you, find probably some obstacles in the process of getting to completion or successful completion of the case, but go with you and dance with you, or the patient that is going to become a stone in your shoe and it's going to trip you in the process and end up having a negative situation. So if you learn to identify the patient right away, then you know how to handle situations, how to probably behave, how to manage this patient, or simply from the beginning, make the decision of not working with this patient and let this patient go. Sometimes we can let the patient go. We don't have the obligation, of go through the process of working with a patient. And that have a lot to do with the ability to communicate. We have to be excellent communicators. We have to be able to create positive engagement. If you cannot communicate and engage with a patient, don't take that patient, don't work on that patient, send the patient somewhere else. Not everybody can communicate with everybody. Not all the personalities match, not all the personalities flow and work the same way. Sometimes it's better to handle a shark than to handle a complicated patient. And many, many years ago, I was visiting in Tampa, the Scientology group. I attended a meeting with the Scientology group, and they were talking about the fact that 2% of the population is composed of sociopaths. And these sociopaths, no matter what you do, you're never going to be able to handle these people the right way. They are going to create problems for you in your practice. I was checking the incidence of sociopaths today, and what I found is that 3.7% of the population today are sociopaths. So we have an increment of 1.7 sociopaths in the population, and surprisingly enough, 5.5 of the 100% sociopath population are males, 1.9 are females. So it seems like although there is a lower group of guys seemingly attending the dentist, guys have the tendency to present potentially more problems than females. So important to understand the fact that if you do an early identification of the sociopathic behaviors in your practice, you have the ability to make decisions, whether to work with those patients or don't work with those patients. And if you work with those patients, what are you going to do? Are you going to go all the way and do risky procedures? Are you going to be more conservative in the type of procedure that you're going to do with these patients? Every monkey knows in which tree to climb, and you never see the monkeys falling far from the branches. You need to know which patient to treat. You need to identify the person that you're going to treat, and doing a good identification of the patient that you want to work with is going to help you. It's going to help you because you are going, again, to have a solid group of people that you know are going to dance with you to the song and are going to flow with you. And they have the same interest that you have, which is taking them from a problem that is their own personal problem into a solution that will resolve and improve their conditions of life. It's going to improve their quality of life if you together go through completion of the dental-related situation that they are presenting with. Now, what is complex for you may not be complex for me, and what is complex for me may not be complex for you, because complexity is relative to expertise, and expertise changes from person to person. And you need to be aware of what you can do, and you need to be even more aware of what you cannot do. The type of patient that you can treat, the type of patient that you cannot treat, and the type of patients where you are taking chances. Taking chances is something that is very delicate, and taking chances is related to the amount of wisdom that you have. It's also related to emotional intelligence, which in doctors is usually low. It's usually low because doctors get into a process of training, studying, and learning early in life, and we give so much attention to academical training that we forget sometimes about emotional intelligence because we want to be intelligent academically. And it's important to bring a balance because emotional intelligence counts when we make these type of situations, in which tree to climb. So the other interesting fact is that what is complex for you today may not be complex for you tomorrow. Important that because things are evolving. We are evolving as clinicians. We are evolving as human beings, and the field of implant dentistry is evolving every day. And an example of evolution is navigation technology. When we look at the navigation technology, which is relatively a new technology in implant dentistry, and I'm going to refer specifically to Navident, for example, we can see that we can actually see in real time where our burr is located within the anatomical structures, the proximity to the adjacent roots, nerves, foramens, whatever. So we are looking at how we are doing all the surgical site preparation as the burr is going into the bone, or whatever that we need to do, even navigating with the osteotome, with any kind of device, because today we can navigate with any type of device within the anatomical structures. And an interesting fact about this technology is that we import the data, we can trace the anatomical structure, we can place virtual teeth, we can add implants, and then we can do the procedure whatever way we choose to do the procedure. But the important thing is that this case that I'm showing you is behind, because even navigation technology have evolved, and this case was done with the older technology for navigation technology. For example, in this case, Naviden changed every single component that they utilize today to make navigation easier, faster, more simple. And today we see companies like Jomi, like XNav. So navigation have gone through a process now of evolution, and they have been moving along super, super fast. So evolution is something that is ongoing even in the new technologies at a very high speed. Then it comes to the question of what technique do we use? Everybody wants to use the technique that is in fashion. And then do we really have to go with the technique that is in fashion? I mean, can we obtain the same clinical excellence utilizing alternative simplified techniques? And what do I mean with that? What I mean is that just like I showed you different type of levers, lever 1, lever 2, lever 3 in the beginning of the lecture, and then when you put different levers together, we had what is called a compound lever. You can simplify procedures and compound the different simplified procedures to get complex, excellent clinical results. But it doesn't mean that you have to go into complexity right away. Learn to work as if you were working with Lego. Yeah, remember the Lego thing that kids used to play? So just think of this as a Lego. Take different techniques, simple techniques, mix them together, and you compound the techniques to get excellent, complex clinical results utilizing simplicity in your procedures. It's like a mathematical equation that is simplified. So we don't always have to use the techniques in fashion. And if you're going to use the techniques in fashion, and this is an example of the fantastic technique by Glockman, Salama, Dutoit, the PET technique, it's a great technique. But if you're going to use this technique, you have to go through a process of training under supervision, do several under supervision until you decide to do it. And what about zygomatic implants? Today, everybody is taking courses and getting trained on zygomatic implants. And zygomatic implants are delicate, are invasive. And basically, if we're going to be working with zygomatic implants, we have to go to the right place with the right instructors and make sure that somebody guide our hands, that we have a big brother in our area where we live to be able to assist if we get into a problem doing one of these procedures. And I'm going to mention, and I'm going to quote Dr. Michael Picos, somebody that is deep in my heart, and his famous quote, "There's a method to the madness." Dr. Michael Picos is one of the most methodic person that I have seen in my career. And he's a guy that always follows a very organized sequential planning and performance process for all his procedures. And this is one of the cases that I assisted him as I was working with him. And this is a beautiful sequential virtual surgery and case rehearsal on a patient where he was gonna harvest some blocks and then place these blocks to do one of his cases. And we can see that even Michael Picos, probably the top guy in blocks in the world, go through a process of planning, go through a process of a comprehensive process of sequential case rehearsal. And he does it in the computer himself before he even goes into the mouse to do it. We happen to have done this one back in 2009 together, and I have his permission to show these images. And it's very impressive because he has always been advocating for three-dimensional reverse tissue engineering for optimal dental implant reconstruction, which means before you go into the mouse, do your homework, do your planning. And another person that always advocates for this is Dr. Scott Gans, that have been lecturing in this topic forever. So we all know Dr. Pico has a very excellent institute back in Tampa, and I strongly suggest that you guys go visit him. Excellent professor, excellent clinician, excellent professor. Today, I personally use less autogenous blocks, and I have the tendency to tend more in that process of simplifying myself. I try to go and place my tenting screws. I love to use the osteogenic membranes. The TXT200 is a membrane that can hold a surgical site very well if it becomes exposed. I'm not gonna lose my sleep if one of my TXT becomes exposed. I would have done many changes to the way that I did the surgery. The surgery was done back in 2007 probably. And I would have done longer incisions. I would have distracted my oblique incisions further away from the area of the membrane. And looking back into this case, many things have changed. I have evolved the way that I do my dentistry and the way that I do my implant dentistry and my bone regeneration. So there's a process of evolution of myself when I look into this picture, although I still doing it very similarly. Today, I had the opportunity to lecture after Buck Lee, who is quoted over here in this slide as well, because he has some of the best papers on tenting and some of the original papers in tenting techniques. Excellent technique that works pretty well as an alternative to blocks, for example. So there's always an alternative technique. And when it comes to soft tissue management, we can decide to work with connective tissue. We can decide to work with a cellular dermal matrix, or we can decide to probably go further into the lingual area or palatal area and look for some of the connective tissue in that area and reposition that connective tissue facially to improve the quality of the soft tissues. We have alternative. We need to find what is the more simple alternative for us, and if it could be utilized within that specific case so we don't complicate what can be simplified. It's important, the sequential virtual planning, because it usually facilitates the process of thought and performance, and we can anticipate complications in advance while we are comfortably sitting in front of our computer looking at the convex CT. And very often we need to create volume of bone, and very often we need to do bone graft, and we can do all that virtually, utilizing the different tools that are given to us by the computer and by the different softwares that are available in the market. Thankfully, many things that were complex in the past are not complex for you anymore. Complex is something that is relative, again, because of evolution of our knowledge, evolution of our clinical experience, evolution of the field. And everything, the biomaterial, everything is under evolution constantly. And it's very important to consider to get right through that process of evolution, to get the right training. You don't want to be trained by Mickey Mouse. You don't want to learn a procedure on Facebook or Instagram Academy. You want to go to a good place. You want to be under supervision, learning and being trained. You need to get the experience in a safe environment that is controlled, where you have somebody to assist you and you get into a tough situation. You have to adopt the right technology in your practice to be able to do the work right. And you need to have a local mentor that is ready to give you a hand and assist you. You have to create a good environment for yourself to reduce the stress and eliminate and reduce the number of complications and complex situations that you may encounter in the field in any aspect of dentistry. And this is an example of how the field has been evolving. This is Implant 9, 10, 11, 13, back between 2003 and 2009. These segmentations would take days. This is the original segmentation with Implant 13 that we did in 2009 for the posters of Materialize that was distributed worldwide. This took me about a week to segment airways, vertebrae, the head and neck, each different bone of the head and the neck, segmented in different colors, and all the structures nicely separated. It took me forever to do this. Today is available at a push of a button, because now they have created presets in the new integrated software. The technology have evolved and digital planning have become super easy to do. And now those same models, I can do them pressing a button, asking the software to give me specifically what I want. And thankfully, I can now go ahead, segment easily, do my virtual planning, do my surgical guides, and easily create that technology within the comfort of my practice in 10, 15 minutes when the same type of process would have taken me probably a day or two. So the field is evolving, and we need to be evolving at the same speed that the field is evolving. So doing something like this in the past would have meant utilizing different machines, different softwares, different technologies. It was a complex process, and this is today at the push of a button within the same integrated software. So we need to always look for simple. Simple is important. Simplification is important. If you consider that a process is going to be complex, you have the choice of not taking any chances. You can always refer the patient out. You can always tell the patient that you don't feel comfortable doing the management of that. There's nothing wrong with that. Sometimes we have the knowledge, but we don't have the desire to do it. Sometimes we have the knowledge and we want to do it, but the patient may have a complex personality and we may not have the desire to do it. So all these things have to be taken into consideration. So try to keep everything within your scope of expertise. Try to keep everything within the scope of experience, or simply refer the patient somewhere else to somebody that is going to feel probably more comfortable dealing with the personality, dealing with the complexity, dealing with whatever that you don't want to deal with. Because it's even a factor related to whether you want to do it or not. You may know how to do it right, but you may not want to do it. And probably one of the most important and forgotten aspects in dentistry, generally speaking, and in implant dentistry, is that we need to set expectations. Expectations from the very beginning makes you or destroys you. And I usually refer to the Prada bag example. And the Prada bag example is an easy one. It's mentioning a patient that how would they feel if they walk into a Prada store and they see a beautiful Prada bag and they pay for the Prada bag, but they walk out of the Prada store without the Prada bag that they paid for. They would feel like they were robbed, that somebody had stolen from them because they paid for something, but they didn't get it. And in my case, that I have to deal with pain or facial pain and dysfunction, which is subjective and it lacks objectivity. There's nothing concrete that you can grab, that you can touch about pain management. It's important for the patients to understand that they may spend a good deal of time coming for healing, because that's what we're giving. We're giving healing, but we have no way to quantify the healing. That they might spend an X amount of money, but they may walk out of the practice without the perception that they have got what they came here for. So the setting of expectation is super important in a practice. There are also occlusal and craniomandibular standards that we have the tendency to forget as we are doing the work, because there are so many aspects involved in getting a good job in this field that we have the tendency to forget that at the end of the day, occlusion has so much to do with the maintenance and the longevity and the stability of a case. And when it comes to occlusion, I could not think of a better classic book than the textbook of occlusion by Molsar, Carlson, and Roth, a book that was published by Quintessence in 1988 and that's still up and current. And in my opinion, the most complete, best book of occlusion, because these people did not follow any type of a specific philosophy. These people basically went and they created the concept, or not created the concept, they mentioned it and presented the concept without taking positions. So it's a book that you can open, you can read a very well-described concept and assimilate the concept with a lot of reliability. So the concepts are very basic. These are the main concepts that we need to keep in mind in implant dentistry when we get into the part of restoring, respecting and reconstructing the very likely lost vertical dimension. We tend to lose vertical dimension as life goes on. And not only that, but in the clencher patient, usually the passive eruption process doesn't really work well because it's very affected. So vertical dimension, we're going to have the tendency of losing it, whether because of grinding or either because there can be a tendency to lose it as the patient have been doing the different parafunctional aspects. The curve of SP very often is affected. The plane of occlusion not only sometimes is lost, but it also has to be reconstructed as the reconstruction is being done. The overbite is an important factor that has a lot to do whenever there's parafunction, whenever patients have to go into eccentrics, for example. The same happens with overjet. Patients have the tendency throughout life to lose the anterior-posterior mandibular position, which sometimes is referred as centric. And the mandibles usually have the tendency to go backwards and upwards, affecting the health and the functioning of the good complex of the TMJ. So it's very important to respect those anterior, posterior, and lateral mandibular position, because the combination of those is what gives us centric relation. And can we restore each and every patient in centric relation? That's a good question, because to properly restore a patient in good centric relation, we need to have a good health, and we also have to have balance in the different anatomical structures that are involved. And sometimes the left side is not necessarily like the right side, and we don't have equally balanced and good structures that can be positioned and repositioned the right way. So it's very important to understand all this concept to be able to apply the concept and do things right. Then we need to decide what kind of occlusal design are we going to be implementing in this type of patients, and how are we going to create our occlusal setup for the patient, and how are we going to facilitate the interaction of the muscles, the occlusion, and how is that going to affect the head, neck, and face system. So occlusion becomes a big deal, a big situation, especially today that more dentists are doing full mouth restoration, full arches, and these arches are being connected to implants. And in reality, once the way that we do this type of restoration and the way that we create the anchorage with the implants for this restoration is really going to create a big effect. And that's why I started showing you the different leverage mechanisms of the head and neck and the mandible, because the way that you are doing this reconstruction will create an effect to remote areas as far as the hips and even feet and knees, because everything in the human body works as a domino effect, and the mouth is one of the most important factors affecting that domino effect of biomechanics. Aesthetics may not always be the chief complaint. We dentists, we always think of aesthetics, and we have the tendency to think of aesthetics as a primary component, but function is always a case requirement. Anytime that we're going to work with a patient, we need to create a type of work that is going to allow functionality in the patient. Aesthetics should never compromise function. When we sacrifice function because of creating aesthetics, we are creating a problem that may not be obvious right away, but with time it's going to be building up. And that really is sad, because that is going to affect the long-term stability of any case that we are creating with a patient. So we have to be very careful with some new tendencies today in which we try to create like flashy, booming aesthetics, but that aesthetic may be in the way of function, because remember that we have envelope of function, we have to go into excursions, the mandible have to sometimes do some type of movements as the patient is chewing, swallowing, talking, and even as the patient is experiencing parafunctional habits. And we never want that the aesthetic design becomes a fence, an obstacle in the process of doing what the mandible is intended to be doing under the control of the muscles and ligaments and the proprioceptive and neurological system. Budget can make a case very complex, or budget can facilitate the way that we perform in a case. So there are cases in which there's limited budget, and a normal everyday human being, as a clerk, somebody that works for UPS, just delivering the mail, or somebody that works in any office in the government, any everyday person may present with a problem, and it will likely present with a limited budget, looking for solutions. So we also need to understand that many of these pain patients that we receive in our practice are human beings with terrible dysfunction, with pain, terrible pain, and also with terrible aesthetics, and usually missing more than one tooth or a big group of teeth, or with defective restorations. And usually I like to 3D scan my arches and look at the arches in the computer and sit down and go through the process of evaluating the pictures and trying to see things. And if you are mainly into cosmetics, one of the first things that you're gonna notice is that patch of resin that was placed into that central that seemed to have been placed with the finger, not even utilizing a spatula, and is blocking the space of the papilla. You can see different abfractions and some radicular cavities, and you can also see missing teeth. And I invite you not to only look for that, because you can only look at the fact that this patient is missing the midline. We see that there is an imbalance in the dental midline. We see that there is an imbalance in the skeletal midline, which is usually at the same position where we see the frenums. So we see that there is a huge deviation of this mandible to the left side. We also can see that there is a big discrepancy between the skeletal midline and the dental midline. So we cannot be only looking at dental midlines. We can see that we have a very poor occlusion setup, lacking contacts in the posterior aspect, either because these teeth are not into occlusion or because they are simply not there. The patient has some edentulous areas. So are we running right away into filling the gap, placing implant and just punching the hole, or are we gonna actually modify the occlusion of this patient in the process to try to improve function and eliminate dysfunction, and in the process, try to eliminate pain in this patient? So what we see over here is a patient that is mainly occluding on one premolar on each side and creates what is called by no-shear method the rocking arches. And the rocking arches are basically arches that work as a rocking chair. They don't have a stability, and we need to help a little bit in the redesign of the occlusal setup of this patient. So there's more stability, better bilateral and anterior posterior stability, better performance of the disocclusion of this patient. And again, remember, this is a patient that has a very limited budget. So we need to see how we manage the case with what we have. And one of the first things that we have to do with a patient like this is utilize splint therapy. And in this case, with so many problems, we cannot use a single splint. We can use what is called a bi-splint, upper and lower splint. And we start by creating an upper splint with the right plane of occlusion, with the right curve of SP. And then we build the lower splint versus the upper splint, or the upper splint versus the lower splint. You need to start with one where you have the best dimension that you can give. And these splints have to be adjusted and balanced periodically, because the patient is going to be changing a lot the contacts and the way that the mandible is actually closing and coming into contact. So we need to make sure that periodically we keep balance, and we try to recenter the midline in this splint, and we try to improve the anterior posterior position in this splint. And if the patient is missing posterior molars, we can create a little extension. So now we replace the function of the missing posterior molars, and we try to get the best occlusion and the best distribution of forces that we can. If the patient is a clencher or a grinder, and if the patient has trigger points, we could consider utilizing botulinum toxin as an adjunct for the management of this patient. And there are different muscles of the head and the neck and the face that we may need to inject in different areas, with a management that we usually try to do, which is sequential. A single application of Botox is not going to do it. We are not just placing Botox for placing Botox. We are placing Botox for elimination of trigger points, for muscle relaxation, and to decrease the frequency and the intensity of the forces. We don't want the forces to be applied as often, and we don't have the peak of those forces to be so high. And Botox is an excellent help in this type of situation. So now we have been working with this patient several months. Pain have been eliminated, function have been restored. But this patient who was originally diagnosed with trigeminal neuralgia did not have any trigeminal neuralgia, didn't have to be anymore on the trigeminal neuralgia medication. It's a normal patient that was having standard myofascial pain and TMJ disorders. So now we have a dental patient, we have an implant patient, and we can see again that we have a huge discrepancy of the skeletal midline. And we start getting through the virtual process, the sequential planning, and everything starts with planning the end result, which are the prosthetics, the teeth. Then we go through the process of selecting the implants, implant width, implant length, implant position, implant angulation, implant design, just as Dr. Karmish described in comprehensive implant dentistry. And we go through the process of placing crowns and organizing everything. And this is not a full mouth restoration. We were only able to do some part of the work that we wanted to do because the patient could not change some of the old bridges, but we took the budget to work in the areas where we really needed to do the work. The most important area that would affect the dysfunction of the patient and would help eliminate the pain as much as possible. This is articulating paper, horseshoe-shaped articulating paper, very important to have when we work with arches. Probably the best brand in the market is Ardent. It's an excellent brand. It gives you the ability of distinguishing within a soft contact and a harder contact, just looking at the penetration of the point of contact, because it doesn't only give you the mark within the splint, but it also, if you look at the articulating paper, you're gonna see if a specific contact is penetrating more than the other. And that way you can balance even better. And we want to balance in centric and we want to balance in eccentric. And now we went from having 2 splints to having the patient with a single splint, one at night, one during the day. Why? Because a patient can be having parafunctional habits at night, but a huge percentage of patients also have parafunctional habits during the day. This is an additional patient, somebody that is a heavy clencher. It has a curve of SP that is off. It has a deep bite, very poor interocclusal space, and have over-eruption. And if you look over here, I have made a list, which is a specific diagnosis of the occlusion and parafunctional related situation of this patient. I have a list within my chart, and based on this list, I'm gonna make decisions of what to do for the patient. This is an orofacial pain patient that was also managed. And then after doing all the management, look at the deep bite, look at the problem with the curve of SP, look at the interdental spaces, which are limited. So once we did all the TMJ and orofacial pain management, we proceeded to do some implant work on the patient and some reconstructive work. And we also did management utilizing botulinum toxin as an adjuvant and as some alternative procedure to help a little bit with some of the issues that the patient was having. And this patient was basically immediate loaded because we knew that now we had better control on the forces. And we went through the process of doing the sequential planning, doing all the case virtually. And in this type of case, we utilize SEDEX technology to make the delivery of immediate crowns right after the implant placement. And each and every case that I've been showing you today have been in the mouth for several years, at least 7 years in the mouth. So all these cases are very stable cases that have been a long time now functioning. This is another patient, very low budget, very cranky guy, very aggressive, neurotic, the type of personality that we usually don't want to have to be dealing with. He's a clencher. He has TMJ pain. He have also a rocking situation, what I mentioned to you before. We need to eliminate pain for him. We need to restore function, and we need to somehow build up the posterior segment. And this guy have big limitation in reference to the budget. So we know that we're gonna have to stage this case. So we go through the process of doing an evaluation for occlusion, and you should look at the models 360 degree and even look at articulated models from behind. So here, virtual models play a very good role. Then we go to the process of creating a diagnostic WhatsApp utilizing virtual teeth, fixing the upcoming occlusion that we intend to create in the computer is super good because we can do it as we are occluding the patient virtually. We look at the corrections that we have to do from the bone and the soft tissue standpoint, and we get to work. We do the identification and the diagnosis of each and every aspect. Actually, this crown that you see in the red circle is a crown that became a point of argument because he didn't want to change it. And he said to me, do what you need to do, that when I'm ready, I'll change it, and the problem is money. So I said, okay, let's go. So we went through a process of doing the sequential 3D reconstruction, the implant planning. We knew that we had to do some sign of graft. We went ahead and we looked at the proximity to the inferior alveolar and the mental foramen, select the implants. We did a segmentation of the roots adjacent to the implants to make sure that we were not going to hit any root during the surgical process, remove the bridge, remove crowns, re-prep, place temporary crowns, place the mandibular implants, went into a 3D guide design also, and we did surgical guides, and we did our 3D models and our digital temps. We were doing everything. This is back in probably 2014 or 2012. We did our incision, our flap elevation, and we went through a process of doing a computer-guided surgery. And we got very nice implants, very nice temporary crowns, and a beautiful case that came up being super nice with a nice soft tissue management. We did improvement on the soft tissues, eventually doing an apically repositioned flap. We did our post-surgical convincity to make sure that the implants were where we wanted them. And then we went into doing the restorative process, improving those problems, the plane of occlusion, the curve of speed, as much as possible within the budget of the patient and within what we could do to improve. So sometimes people cannot afford perfect dentistry. Sometimes people cannot afford full dentistry, but we can do upgradable dentistry little by little. And little by little, we finish what we needed to do for the first part of the process. Then we deliver, again, a device that the patient could use to work as a bumper. Just think of a night guard or think of a splint the same way that you would think of the bumper of your car. You would never go into a highway without a bumper in your car. If you crash, the bumper is going to absorb some of the forces. Not all the forces, not all the damage, but it's going to absorb a great deal of the forces. It is the same with splints. Every time that the patient grinds or clench, it's going to absorb a big percentage of the forces, and it's going to create a dispersion of the forces. And you, as a clinician, you have the control of the vector and the dispersion of those forces. And the way that you disperse the forces will have an effect in the muscles and in the proprioceptive system. This is the first cleaning that the patient had after the pandemic, and we can see that he wasn't cleaning very well. So we had to talk to him, but it's a patient that is actually happy, no pain, no dysfunction. It's a totally functional, happy patient today. And we went through the process of maintaining good occlusion, a good center of forces, utilizing this technology, the T-scan, in conjunction with electromyography. We can see here that we did a sequential adjustment to get the patient as good as possible from the occlusion standpoint. Functional and parafunctional aspects that affect our everyday life as dentists. And we have to start by understanding that there is a huge difference between bruxism and clenching. Bruxism and clenching are not the same. People have the tendency to talk about bruxism as if it was clenching, or clenching as if it was bruxism. And bruxism is one thing, clenching is another. When you are bruxing, you are grinding, you are wearing down surfaces. When you are clenching, you are holding usually the mandible and the maxilla in a static position, and you are applying a lot of pressure, and you are triggering the muscles to actually contract, and you are holding that contraction under a very aggressive force. Clenching can happen in a set position, or the mandible can move into a position, find an obstacle, and clench against that obstacle. people don't necessarily clench the same way and in the same position. People can clench in different positions. But again, clenching and bruxism are not the same. Don't refer to parafunction as just bruxism, because there are different types of parafunction affecting our patients. And if we don't understand what the patient is doing from the parafunctional standpoint, we don't give this patient the right management. The management of a patient that has bruxism is not the same management of a patient that clenches. The management of a patient that have abnormal functioning and movements of the tongue is not the same management of a bruxer or a clencher. And again, when I think of forces in implant dentistry, I have to think of my very good friend, and I hope he's resting in peace right next to God and having some fun in heaven. My friend Karmish, who brought an excellent compendium, an excellent indication in comprehensive implant dentistry, contemporary implant dentistry, about how to handle biomechanics and how to set up occlusion and create the implant occlusal design for our patients. Karmish, thanks God, put it together the right way, did a fantastic job explaining us what to do with the forces so an implant restoration could survive forces, not only in function, but also in parafunction. Because function is not really a big deal. The big deal is parafunction. We don't want to pay attention to forces after a bridge breaks. We don't want to pay attention to the forces after the forces affect the periodontum, the bone, the soft tissues, everything, the muscles. So we need to understand what force is. We need to understand the concept of forces. We need to understand the physics and the mechanics of forces. And if we understand that, then we need to understand how to manage the functional and the parafunctional forces, even if the parafunctional forces don't exist. And you can see here on the left side, a prosthesis that was fractured 3 times by this clencher patient. And we had to go and do additional things to be able to make sure that this lady wouldn't fracture the device, because repeating work is not fun. And seeing our work aging faster because of abuse by forces is sad. And Dr. Daniel Paisani wrote this fantastic book and published in Quintessence, the book about bruxism, and I wish the name of the book would have been Parafunction and not Bruxism, because I think he got very limited in the title. But it's okay, he did a great job, at least somebody put it together. And the occlusal and the parafunctional related complications don't discriminate size and don't discriminate complexity. Parafunction can destroy a whole dentition or can destroy a single specific tooth. But if we don't identify what happened and we don't pay attention to the forces, and if we don't address the issue, it's going to keep on destroying whatever we put there. So the first thing that got destroyed was the tooth. The next thing that is going to be destroyed is going to be the solution, the implant that you placed there, because in reality, you didn't solve the problem, which was the forces applied to that specific tooth or that group of teeth. And when we think of forces, don't think only of articulating paper. Think of everything that has to do with the forces. You know that any time that you're dealing with a heavy clencher, and you need to know that it's a clencher, not a grinder, and vice versa, because we easily as dentists identify the grinder, but very often we don't identify the clencher, and the clencher is the bad guy. The grinder is the easy guy because you identify it. The clencher is the bad guy because it goes unnoticed. So heavy clenchers that will have implants need to undergo a very thorough process of evaluation and investigate the effect of the forces. What are those forces affecting? Then you need to create some strategies to decrease that frequency, that duration, and that intensity of those forces. And then you need to do a very good balance of the static and dynamic forces and create an occlusal setup that will allow you to work with those forces the right way. Then, if you have a heavy clencher or even a heavy grinder and you're going to be working with implants, you need to go back to comprehensive implant dentistry and review every aspect that you need to keep in consideration to create an implant protective occlusion scheme. And that involves the bone quality, the length, of the implant, the width of that implant, the design of that implant, the length of that implant, the width of that implant itself, the angulation in which you're going to place it, the position, the abutment connection that you're going to use, what type of prosthetic design, if you're going to do wider occlusal tables, narrower occlusal tables, longer crowns, shorter crowns, and you need to keep on balancing the occlusion, and you may need to balance the occlusion more than one time, and you're going to need to periodically review the occlusion, because occlusion is not static, occlusion is dynamic and changes, and ideally, give that case an insurance, and the best insurance for that case is to build an orthotic device, a device that will work at the bumper of your car and will help you balance the forces and protect your beautiful restorative material and the implant bone restoration complex that you have created. Botox sometimes is a necessity, and sometimes we have to give the patient Botox periodically to be able to decrease the forces, because some people are simply going to clench and are going to clench aggressively, and they're going to break whatever you put there. Our abnormal forces are going to break everything, are going to complicate your life, are going to accelerate and assist in the bone loss process. Phrenitus is more common than what we think, and a huge percentage of these are lost because of the effect of the forceps, although we don't identify that that was the reason and the source. So it's very important to utilize splints, to reorganize occlusion, to sometimes utilize alternative techniques like Botox, for example, and to utilize medication. Some patients, you will need to work with a physical therapist or a neuromuscular therapist to help them. Do the early recognition, do the prevention, do the management, because if you recognize late, you're going to have to deal with the complications, and you're going to have to do repairs, and you're going to have to basically put the fire off when you can actually prevent that fire. It's very important to prevent during implant therapy, and it's very important to recall the patient and maintain the patients, not just for periodontal related situation, but also from the forces standpoint. You need to identify the clencher, the grinder. You need to look for crack or crease lines in the teeth. You need to know if the patient is waking up with headaches, because that will tell you likely that the patient was clenching the whole night or having parafunctional habits. You need to know if the patient is having a sore jaw and if it's having pain in the facial muscles. Look for wear facets, look for clicking, look for grating noises. Check the splenius capitis, which is the muscle in the back of the neck. The splenius capitis is a muscle that tells you a story. Learn to palpate the splenius capitis. Learn to palpate the elevator of the scapula. And remember that these same forces that are attacking your teeth are going to attack your implant links, are going to attack the bone, the implant, the abutment, the prosthesis, and something may fail. And you want to decrease that failure. So very important to manage the excessive parafunctional forces and to do the early recognition. I would like to finish by concluding that it's very important to recognize the personality of a patient, that it's very important to train in the right place, with the right people, on the right technologies and techniques. And it's very important to use the right biomaterials, to have everything that we need to do the work right, to have enough time to do what we need to do well, and that we need to do early recognition of the complexity issues that will allow us to make the right decisions and decide the course of treatment. With this, I thank you for your attention today, and I hope to see you soon.